If your insomnia feels random, stubborn, or like it ignores every sleep tip, there's a chance it's not just insomnia. It might be a signal from something else going on in your body or mind. The goal isn't to self-diagnose. It's to notice patterns that make a deeper cause more likely. Because when the driver is different, the fix is different too. In the next few minutes, you'll learn the most common warning signs that your sleep problem may be secondary. Think of these as clues you can bring to a clinician or use to guide what you track. Some causes are medical, like breathing issues or hormone shifts. Others are behavioral, like timing, light, or substances. And some are psychological, like anxiety loops that keep your brain on alert. If you recognize yourself in several of these, that's useful information. It means your insomnia deserves a wider lens, not more willpower. Moving to slide 2. First clue. Your nights vary wildly, but your days don't explain it. One night you fall asleep fast, the next you're awake for hours, even though you did the same things. That kind of inconsistency can point to hidden triggers, like caffeine timing, alcohol rebound, late light exposure, or stress spikes you're not labeling as stress. A simple way to test this is to track inputs, not just sleep. Write down caffeine amount and the time you had it. Note alcohol and the time, record exercise timing, and capture your last hour, bright screens, work email, intense conversations, or doom scrolling. The point is not perfection. It's to see whether insomnia follows a predictable chain. If it does, the sleep problem may be downstream from a timing or arousal issue. And that's good news, because patterns are actionable. Random insomnia feels scary. Moving to slide 3. Second clue. You're exhausted, but your brain won't power down. Your body feels tired, yet your mind is alert. Scanning, planning, replaying. That pattern often suggests hyperarousal. Your nervous system is stuck in on mode. Anxiety is one cause, but it's not the only one. Chronic stress, unresolved grief, trauma history, and even overtraining can keep your baseline activation high. You might also notice physical signs: tight jaw, shallow breathing, a racing heart when you lie down, or a feeling of dread about the night. If this is you, the insomnia is less about sleep skill and more about safety signals. Your brain is treating bedtime like a threat. Helpful tracking here is simple. What are the first 3 thoughts you have when you turn the lights off? If they're consistently urgent or catastrophic, that's a strong clue. Addressing the driver often starts outside the bedroom. Moving to slide 4. Third clue. You fall asleep, but you don't stay asleep. You wake up at 2 or 3 a.m., and your brain snaps awake like it's morning. Sometimes that's behavioral, like alcohol wearing off or blood sugar swings after a late heavy meal. But it can also be medical. Sleep apnea can cause micro-awakenings you don't fully remember. Reflux can flare when you lie flat. Pain conditions can spike when you stop moving. And mood disorders can show up as early morning waking. The key is the quality of the wake-up. If you wake up gasping, with a dry mouth, or with a pounding heart, that's different from waking up because of noise. If you wake up with burning in your chest or throat, reflux becomes more likely. If this pattern is frequent, it's worth bringing specific details to a clinician, because can't stay asleep has many drivers. Moving to slide 5. Fourth clue. You snore loudly, or someone has noticed pauses in your breathing. People often think sleep apnea only affects certain body types, but it can show up across many. The bigger signal is unrefreshing sleep. You can spend 8 hours in bed and still wake up foggy, with headaches, or with a sore throat and dry mouth. Another clue is daytime sleepiness that feels heavy and uncontrollable, especially in meetings or while reading. Apnea can also raise nighttime heart rate and cause frequent bathroom trips. If you suspect this, the most useful step is not guessing. It's documenting snoring reports, morning symptoms, and whether you wake up choking or with a racing heart. A clinician may consider a sleep study. If apnea is the driver, classic insomnia advice can miss the point, because the problem is disrupted breathing, not motivation or discipline. Moving to slide 6. Fifth clue. Your legs won't settle. You lie down and suddenly you feel crawling, tingling, or an urge to move, especially in the evening. That can fit restless leg syndrome, which is a neurological sensory motor pattern, not just fidgeting. It often improves with movement and gets worse at rest. Some people also have periodic limb movements during sleep, where the legs jerk without awareness and fragment sleep. Low iron stores can be associated, even when hemoglobin looks normal, and certain medications can worsen symptoms. The important warning sign is the timing. Symptoms ramp up at night and interfere with falling asleep. If that's you, track what it feels like, when it starts, and whether walking helps. Bring that description to a clinician. When restless legs is the driver, the most effective plan focuses on that condition, not on forcing yourself to relax. Moving to slide 7. Sixth clue. Your sleep shifted with a life stage or hormonal change. For many people, insomnia appears with perimenopause or menopause, pregnancy, postpartum changes, or thyroid issues. Hot flashes and night sweats can wake you up, but hormones can also affect mood and body temperature regulation, making sleep lighter and more fragile. Thyroid overactivity can feel like internal acceleration, fast heart rate, heat intolerance, and trouble settling. Low thyroid can bring fatigue, but still disrupt sleep through mood changes or discomfort. The warning sign here is clustering. If insomnia comes with new temperature swings, palpitations, unexpected weight changes, or menstrual changes, it's worth mentioning. You don't need to diagnose which hormone. You just want to connect the timeline. Sleep is tightly linked to the endocrine system. When hormones shift, sleep architecture can shift too, and the right evaluation starts with that context. Moving to slide 8. Seventh clue, your mood changed first, and sleep followed. Depression can look like trouble falling asleep, early morning waking, or sleeping too much but still feeling drained. Anxiety can create long sleep onset, frequent checking of the clock, and a sense that nighttime is when problems get loud. Bipolar spectrum conditions can include reduced need for sleep during energized periods, which can feel productive at first, then destabilizing. The warning sign isn't just, "I'm stressed." It's a persistent shift in pleasure, motivation, irritability, or racing thoughts that lasts weeks. If you notice sleep and mood moving together, treat that as one system. Sleep is both a symptom and a stabilizer. Tracking can help. Rate mood and anxiety daily from 1 to 10, and note sleep timing. If the curves mirror each other, that's meaningful. A clinician can then assess whether the primary issue is mood, with insomnia as a secondary effect. Moving to slide 9. Eighth clue. Your schedule is fighting your biology. If you're wide awake late and miserable early, you might have a delayed sleep phase. Your internal clock runs later than the social clock. This is common in teens and many adults, and it's not laziness. The warning sign is consistency. You sleep better when you can follow your natural timing, like on free days, but struggle when forced earlier. The opposite can happen too, getting sleepy extremely early and waking before dawn. Another clue is that you can't reset with one early night. Your body just rebounds. Light exposure, meal timing, and consistent wake time all influence circadian rhythm, but the first step is recognizing the pattern. If you've been labeling it as insomnia, you may be fighting the wrong battle. A circadian issue needs a clock-based strategy, not just relaxation techniques at bedtime. Moving to slide 10. Ninth clue. Substances are quietly running the show. Caffeine is the obvious one, but the tricky part is timing and sensitivity. Some people metabolize it slowly and feel effects even 8 to 10 hours later. Nicotine is stimulating and can cause early waking. Alcohol can make you sleepy at first, then fragment sleep in the second half of the night as it wears off. Cannabis affects sleep architecture in complex ways, and stopping can cause rebound vivid dreams and insomnia for a period. Even natural supplements can be activating for some people. The warning sign is dependence. You feel like you need something to fall asleep, or you need something to function the next day. If you suspect a substance link, don't just track the amount. Track the timing and watch for rebound patterns. This is not about shame. It's about identifying a controllable driver that many people miss. Moving to slide 11. 10th clue. Pain, itching, or breathing discomfort keeps interrupting you. Chronic pain conditions can make it hard to find a position that stays comfortable, and micro-awakenings add up. Skin conditions like eczema can flare at night due to temperature and dryness. Asthma can worsen overnight, creating cough or chest tightness. Reflux can cause burning, throat clearing, or a sour taste that wakes you up. The warning sign is that your insomnia is body-led, not thought-led. You're not lying there worrying first. You're reacting to discomfort. If this is familiar, write down what wakes you: burning, coughing, itching, joint pain, or numbness. Also note whether it improves when you change position or elevate your head. Those details matter in a medical conversation. Sleep is fragile when the body is signaling distress. In that case, insomnia is often a downstream effect of symptoms that deserve direct attention. Moving to slide 12. 11th clue: you're doing everything right, but you're spending too much time in bed. This is a common trap. When sleep gets shaky, you try harder by going to bed earlier, sleeping in, or lying down to rest. But that can dilute sleep drive, the natural pressure that builds the longer you're awake. The result is more time awake in bed, more frustration, and a stronger association between bed and wakefulness. The warning sign is math. You're in bed 9 hours, but sleeping 6. That gap matters. Another clue is clock watching and repeated attempts to force sleep. This doesn't mean the cause is purely behavioral, but it can amplify any underlying issue. A clinician might consider behavioral insomnia strategies like stimulus control or sleep restriction therapy, done safely and thoughtfully. The key takeaway is that effort can backfire when it increases time in bed without increasing sleep. Moving to slide 13. 12th clue: your insomnia comes with red flag symptoms that should move you toward professional evaluation sooner. Examples include chest pain, fainting, severe shortness of breath at night, or new neurological symptoms. Also pay attention to extreme daytime sleepiness that could make driving unsafe, or insomnia paired with loud snoring and witnessed breathing pauses. Another red flag is a sudden major change in sleep with no clear trigger, especially if it comes with weight loss, fevers, or persistent night sweats. And if insomnia is paired with thoughts of self-harm, that's an urgent situation. The practical move is to shift from tips to data. Bring a short sleep log, your main symptoms, and a timeline of when this started. Ask directly what conditions should be ruled out. You're not being dramatic. You're being precise. Sleep is a vital sign. When it changes sharply, it's reasonable to check whether something else is driving it. Moving to slide 14. To wrap up, the big idea is simple. Insomnia is sometimes the main problem, and sometimes it's a messenger. The warning signs are patterns, like 3 a.m. wake-ups, snoring and gasping, restless leg sensations, hormonal timelines, mood shifts, circadian mismatch, substance rebound, or body discomfort that wakes you first. If you want one practical next step, start a 7-day log. Track bedtime, wake time, estimated sleep, caffeine and alcohol timing, naps, and the main reason you woke up. Then look for repeatable links. That kind of clarity can speed up the right conversation with the right professional. If you found this helpful, subscribe for more evidence-informed explanations about sleep and behavior. And for a quick check-in, comment A or B. Is your bigger issue falling asleep or staying asleep? This information is not a substitute for medical advice.